Hello, everybody. This is Dave of the SIR Resident and Fellow section. Thank you for joining us again tonight. We're really excited for a great talk. Earl is one of the RFS members from the Pediatric Service Line who set up this talk, and I texted you guys an email if you're looking to get more interested in the Resident and Fellow section. Join us on service lines or the different committees. We're always looking for more help. Basically, members like Earl and myself are what kind of make these successful on top of you guys joining. When Dr. Kukreja starts his talk, he's going to ask you guys some questions. So if you would be so kind as to reply in the question pane, we're going to make it a little more interactive. So with that, Earl, I'm going to hand it over to you to introduce our speaker.
Great. Thank you, Dave. Like Dave said, I'm Earl. I'm an R2. I go to Baylor College of Medicine. It's my pleasure to introduce Dr. Kamlesh Kukreja. He's currently the Section Chief of Interventional Radiology at Texas Children's Hospital and also a clinical professor at Baylor College of Medicine as well. A little brief background on Dr. Kukreja. He did his fellowship at, I believe, Miami Children's Hospital and also a fellowship in interventional radiology at Jackson Memorial Hospital. Among his many accomplishments, he's also was awarded the CAPI Award for Best Electronic Poster at the Interventional Pediatric Meeting. His clinical expertise actually and research interest is actually in DVTs in children, IVC filters, pediatric cancer, and liver transplant interventions. He performs all types of interventions at the Texas Children's Hospital, and is here to give a little overview and introduction on what a pediatric interventionalist does. So let's welcome Dr. Kukreja. Thank you for coming, and I'll give you the floor.
Thank you, Earl, and thank you, Dave, for introducing me. Thanks for the wonderful introduction, Earl. So we're going to try to get an overview of what exactly pediatric IR is and what a pediatric interventional radiologist does, because I'm sure a lot of you wonder what exactly do these guys do. So before I get started, I actually wanted to get a feel from the audience to see if you could chime in for the next few minutes, either via speaker or by putting in a response chat to see what you know about pediatric IR. It could be one sentence, two sentence, whatever you prefer, just so I have a feel of how many people know, how many do not have much information about this specialty. Okay. All right, well, that's good response. Thank you, everybody, for sharing that information with me as to what your knowledge level is in for pediatric IR. So it seems like from the responses, at least, what I received was there were a lot of audience that does not have a good clue of what pediatric IR is. And I am sure I will not be able to summarize in this talk what we do, but I can at least give you a preview of what is pediatric IR. So we're going to get started now. So the current situation of pediatric IR. Now, this is a little bit of old study, but it still gives you an idea of what pediatric interventional radiologist workforce is. There was a survey in 2005 by Sidhu et al., which showed that there are 110 interventional radiologists internationally, of which 79 are based in the U.S. And at that time, it was perceived that the requirement for international pediatric interventional radiologists would be about 32%, and in the U.S., it was at least 25%. And as you can see on job postings recently, there is still quite a bit of need for pediatric interventional radiologists. These IRs come from different backgrounds. Usually, they have completed radiology residency, followed by, most commonly in the past, a pediatric radiology fellowship, and then started working as a pediatric interventional radiologist and gained exposure during being a faculty. Some of them are now going through a pediatric IR fellowship after their pediatric radiology fellowship. And then some, like me, have done an adult interventional radiology fellowship as well, besides the pediatric radiology fellowship. So here's a wide variety of procedures. This is a very busy slide, but all I can say is, there's a variety of procedures that a pediatric interventional radiologist does. And we'll go over some of these in a little systematic format. We'll start with the general procedures, and these are vascular access. One of the most common procedures we do in IR. In children, PICC lines are one of the most common procedures. What is shown here is a sheath needle that is being placed in the arm of a child, and then you can see a PICC line coming from the left side in this child, and this is one of the most common procedure being done in pediatric IR. And just so everybody knows, the most common location based on a study done for evaluation of the location of SVC in a child is always the same. It is between the carina and two vertebral body units is the ideal location where SVC lies, in the SVC right atrial junction is at two vertebral bodies from the carina. So that's one of the common procedures. Abscess drainages, like someone mentioned, we all do that. Here's an example which shows an abscess in the right upper quadrant with the arrow and then extending inferiorly, and this was successfully managed by placing a drainage catheter. The use of ultrasound is very common in pediatrics since we can get very good visualization of a lot of structures. So you'll see a lot of examples of ultrasound-based procedures in pediatrics. Here's another example of a transrectal drainage catheter placement. You can see a large abscess in the pelvis, which is difficult to reach either anteriorly. You can get to it posteriorly, but you still have the rectum located posteriorly. What I have done is going through transrectal approach, which is very common. And the way we do it is, here is an ultrasound image. It's a transabdominal ultrasound. So you're looking at the bladder with the Foley catheter, this demarcated as a star. And then you can see a needle entering from the transrectal approach in the abscess. And then a wire is placed through this needle. This is an Amplatz wire. And over that wire, we place in the transrectal drainage catheter, which is shown in the lateral and the AP projections. The advantage with this technique is decreased pain over the sciatic approach or the posterior approach for managing these abscesses. So another procedure, IVC filters, placement and retrieval. Again, common procedure done in adults as well. The most common indications are prophylaxis against pulmonary embolism and extremity DVT, which they're unable to anticoagulate, or there is inadequate anticoagulation. Here's an example of a filter being retrieved. You can see the snare grabbing the hook of the Gunther-Tulik filter, and the filter has now been placed within the sheath and then has been retrieved now. I think the one thing that I would like to mention that is different from the adult procedures is that in pediatrics, the number of filters placed are very low, so we are able to aggressively take an effort to retrieve them. Usually what I do is whenever I place a filter, I give them a preemptive appointment at 4 weeks and 8 weeks, with the idea being that even at 4 weeks, if the filter cannot be taken out, at least it brings attention to the fact that this filter can be taken out, and is it really the time now, or do we need to wait and take it out at 8 weeks? Here's a pretty cool case. This was a child, a 3-month-old, who had history of clubfoot, and then an ankle mass was noted after spica removal. So it started with an x-ray, and you can see a globular swelling along the ankle, right ankle, and the logical next step was to do an ultrasound and figure out what this is, and it shows this hypoechoic enlargement with color flow within it, consistent with a pseudoaneurysm of the posterior tibial artery. And, in a 3-month-old to do an angiogram and try to embolize it would be a really challenging task, especially going all the way to the posterior tibial artery. So we applied the concept of the femoral pseudoaneurysms to manage this. And here's a needle that has been placed in this in the pseudoaneurysm with ultrasound guidance. And we injected thrombin in this, and then you can see the post-procedure ultrasound that shows no flow, color flow in this pseudoaneurysm with a good response in this patient. So, very good management for a pretty serious problem. Here is an example of venous malformation in tongue. In this patient, you can see that there is significant swelling along the tongue, which after sclerotherapy ×2, you can see near complete disappearance of that venous malformation. Here is the imaging that we all like to see. You can see the pre-procedure venous malformation along the tongue like we saw on the clinical radiograph, and then post-sclerotherapy radiograph demonstrating near complete resolution with a good response in this patient. So moving on to the urologic procedures that we do. Here's an example that is also pretty frequent on the adult side, a patient that has a stag-on calculus of the right kidney, which was referred for a PCNL procedure. Here's the ultrasound, which demonstrates very minimal dilation of the collecting system. And here is, again, ultrasound guidance to place the needle. I was barely able to get onto the calyx in this patient. And this is just a floppy end of a cope wire that is now inside the calyx, and you can see the sheath barely at the outer margin of the calyx, and a huge filling defect of the stone within the calyx. And here is the catheter that was successfully placed after a little bit of work in this patient, and this patient underwent a successful nephrolithotripsy on the next day. Another case, a 15-year-old female with tuberous sclerosis, which is more common in the pediatric population. These patients tend to have a group of symptoms, one of which is development of angiomyolipomas in the kidney. And what you can see is a axial CT scan demonstrating bilateral angiomyolipoma, pretty enlarged, and if they exceed more than 4 centimeters in size, we now do preemptive embolization to prevent acute hemorrhage. So here's the angiogram on the right side. You can see significant diffuse vascularity in the upper pole, AML. However, there is no aneurysm demonstrated in this angiogram, so we chose not to treat this. And on the other side, you can see that there is aneurysmal dilation along the lower pole of the left kidney. So we decided to embolize this, and initially we did the microcatheter access followed by injection of PV8 particles, and you can see the post-embolization angiogram demonstrating an acute cutoff of the angiomyolipoma in the lower pole. And here is the left renal angiogram after embolization. This is pretty equivalent to a surgical lower pole nephrectomy done angiographically. Here's an example of an 18-year-old who came in with a handlebar injury and had active bleeding, and the CT scan demonstrated active extravasation in the area of the liver, in the left kidney, as well as in the area of the liver rising from the left hepatic artery. So there was selective cannulation of the hepatic artery where you can see active extravasation within the liver, and then this was successfully embolized with coils with good resolution. Not very frequent in children to have trauma managed with angiographic approach, but this was one of the cases. Here is again a unusual case. What you're seeing here is a double J stent in the area of pelvis. This was a double J stent placed within a renal transplant in a patient, and it had migrated from the bladder into the distal ureter. and the urologist was not able to retrieve it. Now, this is a challenging situation for interventional radiologists as well, because the ultrasound does not show any significant calyceal dilation. So to try to get into a non-dilated calyx is a significant challenge. What we were able to do is actually give some Lasix, which dilated the system only by 1 millimeter. And then I was able to place a needle within the upper pole calyx. You can see the contrast injection going down the stent and going into the bladder. So it's able to get into this collecting system, and here's the retrieval of the double J stent using the alligator forceps. So pretty unusual case that could be very challenging in pediatrics to get into a non-dilated system. So moving on, we're going to talk about some musculoskeletal interventions. Here is an example of a steroid injection for juvenile idiopathic arthritis. You can see that the needle has been placed in one of the interphalangeal joints, and then on the right in the elbow joint. What we do is we place 25 gauge needle in the joint, inject a very small amount of contrast to confirm intra-articular placement, followed by injection of steroids for better response in juvenile idiopathic arthritis. And here's an example of another venous malformation. You can see hyperintense signal within the muscular portion of the right forearm with a low intensity area, which is considered consistent with a phlebolith in this patient. And the post contrast in MRI demonstrates enhancement of this lesion consistent with the venous malformation, and again seen as the phlebolith. Here is the access for sclerotherapy. A small needle has been placed and contrast injection has been performed to confirm that there is no drainage of the contrast into the venous system, and then followed by sclerotherapy in this patient. Osteoblast, radiofrequency ablation are also very common in children. Here is an example of a 10-year-old with hip pain and had a femoral osteoblastoma, classic imaging appearance with a central nidus and a surrounding sclerosis. These patients, again, classically present with pain that subsides with aspirin. And here's the CT approach demonstrating the markers of getting to this osteoblastoma. There's the placement of the RF probe right in the middle of that nidus, followed by radiofrequency ablation and addressing this nidus post-procedure. This lesion was very close to the articular margin, and hence we decided to stay a little further back in this case. Again, a very, very rare case. You may or may not see this in your lifetime, but this was a 14-year-old girl that presented with left hip and leg pain, and the radiograph demonstrates a lytic lesion of the left pubis, which was causing pain in this patient, and the diagnosis was a desmoplastic fibroma, which is a very rare condition seen in about 100 patients worldwide, and nobody had a good idea of how to manage this, so IR was, just like it happened, so IR was consulted to help out. And what we did was we placed a needle within this lytic lesion with CT scan approach, and then aspirated some of the contents, and then placed a bone cement, which stabilized this patient, and her pain disappeared. And after that, we've done multiple procedures on this child as well. So the next subset is chest, and we all do chest tube placements for pneumothorax, pleural effusions, and I'm going to show an unusual case that I happen to help out with. You can see that this is a very young child who now has 5 tubes in both chests, and we were kind of talking about this kid as 1.6 tubes per kilo, because this kid was only 3 kilos, has significant edema, So this patient was getting multiple pneumothoraces and was not being able to manage and remove the tubes by the ICU team. So they consulted us, said, can you help out? So sure, here we are with a assessment of these tubes, and what you're going to see here in a minute is the pacification of the bronchial tree through the pneumothorax from the right lower base to the tube. And I was prepared for this based on imaging guidance. You don't want to inject a iodinated contrast in the bronchial tree. So we immediately suctioned this child and reduced the adverse effects of the contrast within the bronchial tree. However, what you're going to see is that the contrast now goes to the other side as well. So it was a case of bilateral bronchopleural fistulae in this child. The traditional thinking and teaching is don't put a tube in a bronchopleural fistula. But now you already have a tube in a bronchopleural fistula, and how do you manage that? So what we were able to do is kind of consolidate the tubes and place a tube at the site of the bronchopleural fistula on both sides. As you can see, that there is a tube that has multiple holes on the left and then on the right. And we put these tubes on suction for 2 weeks and didn't pay attention. Just let the tissue and the pleura pose and not worry about it. And slowly, the ICU team was able to remove one tube at a time, with finally the 2 basal tubes left. And after about 3 weeks, they were able to get all the tubes out. And here is the radiograph in this child, who now has complete resolution of bronchopleural fistulae bilaterally. So something that you don't see very often, but again, in pediatric IR, there's no standard set of, well, can you do this procedure? And we are always thinking innovatively in general for doing different procedures and helping different children. So moving on, GI procedures. Again, we do a lot of liver biopsy. Here is an example of an ultrasound-guided focal liver mass biopsy in a child. Here's an example of a case of a patient who had a liver transplant, a segmental liver transplant, and had elevated liver function test. What you're seeing here is a marker which demonstrates the biliary duct dilation that happens in these liver transplants. Usually from the adult side, you're used to doing PTCs on adults that have cholangiocarcinoma, and then their biliary ducts are super dilated. You use fluoro to get into those ducts. But in children, these duct dilation can be very small. So when you're reading imaging on these children, be aware that the ductal dilation may not be as significant, but the patient may have significant elevation of liver function test. Another examples show the dilated biliary ducts in this child. And what you're seeing here is a needle has been placed from the left side, because a lot of time these are left lobe transplants in children. Usually they get 2 out of 1. So, 2 children can get 1 liver. One can get the right lobe, one can get the left lobe, or an adult could get the right lobe, and a child could get the left lobe. So what you're seeing here is a needle that has been placed in the left biliary duct, and you can see multiple filling defects that are consistent with either sludge or stones, and then you can see a very thin string of contrast that now drains into the jejunum, which is in the right upper quadrant, via the hepaticojejunostomy. So this was a very challenging situation, because we were afraid that we might shear off the connection at the hepaticojejunostomy if we stretch too much. However, I was successfully able to get a wire across, and now you can see the biliary dilation and a complete obstruction in that area. So we're able to place a catheter, and this patient did actually well. Was able to remove the catheter at about 9 months. Another unusual case, this was a female who presented with abdominal pain, was clinically unstable, and the CT was performed, which demonstrated pericholecystic fluid. So the logical next step was to do an ultrasound, which confirmed acute cholecystitis in this patient. However, since the patient was clinically unstable, the surgeons contacted us to see if we could place a cholecystostomy to stabilize the patient, and then they would take the kid to the OR. And here's the example of a cholecystostomy tube placement, which is usually a transhepatic approach to drain the gallbladder, and contrast injection confirmed appropriate placement, and this patient successfully underwent cholecystectomy once stable. So in GI cases, I've included some of the liver transplant cases that we come across frequently. Here's an 8-month-old who had a history of recent liver transplant, and sometimes you don't realize what you don't see instead of seeing something and then trying to find an abnormality. So what you're not seeing here is any contrast in the hepatic transplant in the right upper quadrant. There is no opacification of the hepatic artery. And on selective injection, you can see that there is a tight stenosis in the anastomosis, and there is some flow in the distal hepatic artery, which we were able to selectively cannulate and get across and balloon dilate, and now you can actually see opacification of the hepatic artery. So this was a liver transplant 5 days out post-transplant that was successfully saved by IR. So the last subset that I'm going to talk about is advanced interventions, and those are two subjects that are passion for me. I like doing them. I include the two procedures of thrombolysis and onco-interventions in this subgroup, and we'll start with thrombolysis. So DVT. For a long time, the pediatric hematologists were under the impression, oh, DVT doesn't happen in children. We don't need to do anything. And if you see it, well, you treat it with heparin and all the kids do well. Until the adult hematologist who now started seeing post-thrombotic syndrome in adults as well, time and again, teenagers develop deep venous thrombosis, and by the time they develop post-thrombotic syndrome, they might have been transitioned to the adult hematologist who now has to manage the PTS. So the pediatric hematologist didn't necessarily know that this patient developed PTS. So now there is increasing recognition of deep venous thrombosis in children, and catheters are actually the leading cause in the younger age group. While in teenagers, the thrombophilia or coagulation abnormalities can lead to DVT. And post-thrombotic syndrome actually has been recognized to happen at about 20% of the patients, which means 1 out of every 5 children is going to develop PTS at 1 year follow-up. The management in these patients was heparin, which does not affect the thrombus. It only prevents further thrombosis. So the best way would be to manage it with percutaneous approach, which includes a combination of mechanical thrombectomy, catheter-directed therapy, angioplasty, or a stent. So here's an example of a 15-year-old female who came in with a left lower extremity pain and swelling, and you can see the classical cutoff of the contrast, the meniscus sign that we talk about with the acute DVT, with very little collaterals. You can see a little bit of wire going across, so successfully cannulated thrombus. You can see significant irregularity of the common iliac and the external iliac vein with good flow of contrast into the IVC, which was normal. Something to notice that there's no filter that has been placed in this child during the procedure of thrombolysis. So this patient underwent mechanical thrombectomy, did not respond very well, so I chose to place a infusion catheter for TPA administration overnight. And what you can see is that now there is significant improvement in the flow. There is some irregularity in the common femoral vein, but pretty good in response compared to when we started out. And then there was a pacification of this channel that I initially thought was a contralateral common iliac, and I was not sure what's happening here, so decided to do angioplasty, which did not change the picture. However, what I realized with the midline vessel that I was seeing was a large collateral that was actually draining the flow from the left common iliac into the right common iliac. And this finding with the angioplasty balloon not yielding any waste was consistent with a May-Turner syndrome, which is compression of the left common iliac vein by the right common iliac artery, leading to chronic thrombosis, not chronic, but chronic changes within the iliac vein, and then presenting with thrombosis. So the best management for this patient of this condition is stenting, and this patient underwent stent placement with a good response. And this is a 1-month follow-up, and this patient actually has been doing very well for the last 2 years without any intervention required for stent. Here is the ultrasound images demonstrating good flow within the femoral, the distal femoral vein, and then the popliteal vein. So now I'll talk briefly about onco-interventions or oncologic interventions in children. So here are some numbers to consider. Cancer is actually leading cause of death by disease in the 0 to 15-year age group. And according to the 2007 statistics, it's diagnosed in 10,400 cases a year, of which about 1,500 end up dying. The 5-year survival for cancer in children has increased significantly from 58% from 70s to the 80% in the 2000s. However, there's still scope for improvement. From IR side, the potential weapons that could be used for pediatric cancer are ablation, transarterial chemoembolization, and or chemoinfusion, selective internal radiation therapy, and oncolytic virus injection. And starting with ablation, some of you may have seen these procedures during your residency. Radiofrequency ablation or microwave ablation can be used. The concept is just to heat the tumor or freeze the tumor to kill the tumor cells. Here's an example of a 19-month-old female who had cirrhosis, and the reason for cirrhosis was this rare condition called progressive familial intrahepatic cholestasis, type 2. She was on the transplant list for a liver transplant. However, she underwent a pre-transplant screening MRI, which demonstrated a lesion. And in this particular condition, the most common liver lesion is actually a hepatocellular carcinoma, which was a learning point for me as well. Here's the imaging appearance. You can see this ultrasound, which demonstrates this ill-defined lesion with increased vascularity in the left lobe. And you can see this lesion seen very well on post-GAD imaging. And this patient was already on the transplant list, so if this was not controlled, this patient would have to now be taken off the transplant list, and the surgeons didn't want to operate on this patient because they wanted to keep the belly pristine from liver transplant. So they consulted us, and here is the needle that was initially used to perform the biopsy as well to confirm and provide more evidence for the liver transplant. We ended up doing radiofrequency ablation of this lesion. The biopsy was consistent with hepatocellular carcinoma, like I mentioned before, and this patient was successfully managed with RFA as a bridge to liver transplant. This patient received a liver transplant. 3 weeks later, my one and only case of complete ablation of the hepatocellular carcinoma in a child on an explant liver. Don't get to see it every day. Transarterial chemoembolization or infusion is basically infusion of intraarterial chemotherapy with or without embolization. The potential tumors that could benefit from this therapy are retinoblastoma, which is a tumor of the eye, hepatoblastoma, and then hepatocellular carcinoma. And here's an example of a 3-year-old boy who had bilateral retinoblastoma with status post-chemo. The left eye was in clinical remission, but the right eye had recurrence. So here's the pre-treatment MRI, which demonstrates the hypointense lesion along the posterior globe consistent with the retinoblastoma. Note the other side shows pretty much a scarred appearance of the previous tumor. And here's the clinical exam on fundoscopy, you can see the extensive large tumor before intraarterial melphalan therapy, and here's the follow-up, which basically shows scarring after 3 cycles of intraarterial melphalan. And here's the imaging appearance as we all like to see compared to the pre-procedure imaging, demonstrating again scarred appearance of the right retinoblastoma in this patient. So effective management with the intraarterial approach. And actually this approach is being followed very frequently in pediatrics these days, as they're able to save the vision but also keep up the cosmetic appearance of having the eyeball grow with the child instead of enucleating, which is removing the globe and then having a small orbit compared to the child's face. This was intended to be a video which describes selective internal radiation therapy. I don't think it works. But basically, this describes the concept that with selective internal radiation therapy, you can go into the hepatic arteries, which are commonly supplying the tumor in the liver, and then target them with intraarterial injections of radioactive beads. 2 of these companies are now providing products to be managed in hepatocellular carcinoma and metastatic tumors to the liver, extensively performed in adults, but not much in pediatrics. And here's an example of a patient who had an unresectable HCC. The role of SIR could be an unresectable HCC or liver metastases. And here is a case of an 18-year-old who had an incidental diagnosis of liver mass without any underlying disease. So another fact to keep in mind, that in pediatrics, you don't necessarily have that background of cirrhosis to develop a hepatocellular carcinoma. It's a different variety of hepatocellular carcinoma called fibrolamellar HCC, which develops in the normal liver. So this child or teenager had this huge right lobe mass that was causing significant mass effect on the right kidney, stretching the venal vessels, and also had extension into the portal vein. So transplant or resection was out for this patient. He would be on the transplant list forever and will not get a transplant. So we were consulted to do SIR on this patient, and you can see selective hepatic arterial injection supplying the right lobe tumor, which was then, this is the tumor blush of the right lobe, liver tumor. This patient underwent successful SIR where we initially embolized the non-target vessels, followed by radioactive therapy, and this patient actually tolerated the procedure very well and was stable with radioembolization for 7 months, which is a good prognosis for this patient. Not done everywhere, but I was fortunate to be involved with extensive research work by one of the oncologists at my previous institution who developed an oncolytic virus after 10 years of research. This was only an investigational option available at my previous institute. I'll talk a little bit about it. So why is the appeal of oncolytic virus? Because they can cause direct cell lysis. They can attack the cells that are carcinogenic. They cause self-propagation, so they can multiply within the tumor. They can be sensitized to tumor-specific antigens. The favorable metabolic environment of the tumor is perfect for the growth of these oncolytic viruses. And they are easy to manipulate for safety. So there were different viruses such as herpes simplex virus, varicella virus that was manipulated for injection within solid tumors. And we were one of the centers that were initially evaluating these viruses. And here is a mouse study that was performed. You can see that this mouse was developed in this mouse and was injected with this oncolytic virus. Then you can see complete necrosis within that tumor in this mouse over time. So we've tried to follow the same concept, and here's an example of a cervical carcinoma in this patient, which had very limited surgical options. You can see the needle that has been placed in this tumor, and we injected the virus. Another example of a metastatic Ewing sarcoma that was injected with the virus. The way we started off with this study was we had to give very minimal doses of these viruses because the FDA usually wants to assess the adverse effects before they increase the doses. They want to make sure that the lower doses do not cause any adverse effects, and so these injections were not expected to provide any response, were more for, okay, do these patients develop any adverse effects with these injections? And actually one of the patients developed herpes simplex, not severe, that was bothersome or had any adverse effects. So in summary, pediatric IR is a rare breed. It's growing, and I think it has a lot of potential to grow. It is versatile. We're a master of a lot of trades. We do a lot of different procedures. I think the venous thrombolysis and oncointerventions are future frontiers for pediatric intervention. And all I would say is if you do decide to do pediatric IR or get interested, just be available for consults because you never know what you'll be able to help the child with your expertise. So I think that's pretty much it for me. Thank you for your attention, and I would really like to thank all for contacting me and providing me this opportunity to present tonight. And thank you everyone for joining tonight.
So with that, I'd like to open the floor. I'd like to open the floor to questions.
Muted.
Anyone has any more questions? Well, I have one question actually. You mentioned when you were treating retinal blastoma. Sorry, guys. When you treat retinal blastoma, I know the first line of treatment is to enucleate. Do people now tend to do more chemoembolization of that, or is it still up in the air on what to do?
So actually, there have been studies that have been published that intraarterial chemoinfusion is providing equally good response to what has been the standard of care of enucleation. So as it always happens in medicine, you start off with the challenging cases, which are non-resectable or bilateral retinoblastomas, where you don't want to enucleate both eyes or there's recurrence, which is what is being treated with intraarterial chemo infusion right now. And based on the good response, it is expected that in the future this might become the therapy for retinoblastoma.
Great. We have one question from Ryan. His question is, for the May 3rd patient, did you or the hematologist treat with prolonged anticoagulation after stenting?
So we did the standard of care for management of DVT that I've been involved with is usually 3 to 6 months of anticoagulation, followed by just aspirin for just reducing the instant restenosis in this patient.
Okay, great. Another question from Rajat. Dr. Kukreja mentioned that pediatric trauma is usually not dealt an angiographic approach. Why is this? Are there more evidence-based studies needed to make IR a part of the first-line treatment in these circumstances?
In pediatrics, conservative management is usually considered more important. And what they have found is that in trauma patients, unless the kid's actively bleeding, they prefer to manage the patient conservatively. Most of the time, the trauma could be a splenic rupture or hepatic injury. So those are usually managed conservatively unless they're actively bleeding and having a significant clinical sequelae is when there would be a decision making of whether you need to intervene or take them to the OR. And that's why it's not very frequent that you get trauma interventions in pediatrics.
Okay, another question from the staff. For the 18-year-old male with fibrolamellar HCC, was lobectomy considered, or was the left lobe also involved?
Yeah, so that patient also had the left lobe involvement, and that's why the lobectomy was not an option. We were going to treat the left lobe as well later on after we hit the right lobe with 2 cycles. However, the patient ended up expiring before that and died, so we didn't get an opportunity to address the left side.
Great, thanks for all the questions. We have a couple more. We are compiling a list of major clinical trials in IR. Are there any landmark trials specific to pediatric IR that come to mind, either ongoing or completed, that an interested individual should be familiar with? Clinical trials in IR.
I think the clinical trials specifically in pediatric IR, I'm not aware of any going on at this time. I'm not sure if the audience is aware that pediatric IR is a very new society that has been recently formed in the last 4 years. So we're trying to put our efforts together because all along we didn't have strong numbers, as you can see from my initial statistics, to create an impact. And we do what we do, we just kind of have developed from expertise from a long time, or we think that's the right thing to do and let's do it that way. So we don't have a lot of trials or even combined experience, if you want to call it, to come up with a concise combined results that, should be the standard of practice in pediatrics, because there's not enough numbers most of the time to come up with those conclusions. I mean, I've published some of the papers. The largest study that I published was IVC Filters in children. In about 10 years at my large institution, pediatric institution, how many filters did we do? 33. So 10 years, 33 filters, that's not much. So I think the pediatric IR community is now getting organized to have multi-institutional studies so we could directly impact and provide better pediatric care. So I think the short answer to your question is I'm not aware of any big trials that are currently on for pediatric IR.
Are any concern about stenting in the pediatric population in terms of durability and sizing?
So, the example of May-Turner syndrome that I showed, that's a situation where you have no choice, but you gotta stent, because if you don't, then the kid's not going to do very well. The rest of the situations, we try to be very conservative with stenting in children, because now the stent has to live for maybe another 50 years, and we all know that we don't know if the stent is going to even survive for 50 years if you put a stent in a 15-year-old. So we try to not put stents if we can avoid it and live with angioplasty, but if you have to put a stent, you have to put a stent, and you just work with the consequences. Pediatric cardiology places a lot of stents in some of their population, and I'm not sure if they've published a lot of data about the in-stent restenosis rate in their patient population. The one other thing that I want to say is that as a resident, or by the time you become a fellow or become a faculty, we may hear about absorbable stents, stents that are placed and then get absorbed and become a part of the endothelium. I think those are very exciting for pediatric IR community, because then that could provide us a potential of not necessarily limiting the long-term growth in these patients. And then some of the stents that are now available also can be post-expanded, so you can deploy them and only stretch them to 6 millimeters, and then as the child grows, you can go up to 10, which is a good option in pediatrics if you intend to stent.
So there's a few questions on the training pathway into pediatric IR. A couple of people are not too familiar, and also One is asking, the traditional PEDS IR pathway seems to be transitioning to a 1-year pediatric diagnostic followed by a 1-year IR fellowship. Dr. Kukreja, do you feel that a mini fellowship in pediatric diagnostic or IRDR residency will change this in any way? Will change this in any way?
I feel that many fellowships in diagnostic PEDS or many fellowships in diagnostic PEDS. I'm trying to read this question, and I think I do understand one point about the DR residency potentially affecting the pediatric IR training process. I'm hoping that the pediatric IR becomes a part of the IRDR residency process, and there is some dedicated time for pediatric IR learning during that process. But since the IRDR residency itself is a new process where everybody is learning how we're going to make it happen, it may be a little bit of time before we actually see pediatric IR as a part of that residency. Also, just talking in general, I think for people who want to know more about pediatric IR, I think I would suggest becoming a member of the Society of Pediatric Interventional Radiology by going to the website called spirweb.org, as you can see the bottom of my slide. And then you can interact with more PEDS IR members and then decide what would be the best route to go for achieving the objective of becoming a pediatric interventional radiologist. In my opinion, I think ideally a dual training would be very helpful in pediatric radiology and in adult IR to help you better prepare for any job out there and also become a pediatric interventional radiologist.
He was talking about a 6-month mini fellowship in pediatrics. Would that make a difference?
I think a lot of pediatric IR fellowships are trying to be flexible and provide options. So since we talked about potential routes of getting into pediatric IR would be either a pediatric radiology fellowship or an adult IR fellowship. So say you have completed an adult IR fellowship, you could join a program that offers you a 6 months of pediatric IR and a 6 months of pediatric diagnostics, and you can get more familiar with pediatric IR side of things, because in 6 months after an adult IR fellowship, you should be pretty comfortable with that. Or alternatively, if you come from a pediatric radiology background, then you could potentially go through a training program that can offer you 6 months of adult IR and 6 months of PEDS IR. So I hope that answers the question that we were trying to get to.
There's a question on femoral artery occlusions with angiography in kids. Are there any issues with it? Leg discrepancy, leg length discrepancy? If so, how do you prevent it?
So yeah, femoral artery thrombosis is a very common issue in very young kids. So based on the age of the child, we actually heparinize the child as soon as we get access and place a sheath in the groin to prevent femoral artery thrombosis. Also, if they do end up getting femoral artery thrombosis, sometimes they do. At this point of time, as far as I know, I have not seen a case myself, but there were some cases that were done by cardiology, and they usually manage them with heparin. And these patients do end up developing limb length discrepancy and having some arterial issues 10, 15 years after the occlusion.
I think that's all the questions. Everyone, thank you for the lecture. Thanks everyone for attending. If you guys have any interest in anything Dr. Kukreja talked about, I'm in the pediatric IR pediatric line, and you can go ahead and try to contact me. I'm sure they can give you guys the information, and try to find a lecture out there to give you guys. Again, thank you. Thank you, Dr. Kukreja, and I guess I'll turn it over to you, Dave. Guys.
Thank you, everybody. Good night.